Hello, everybody. Thank you for joining this lunch seminar organized by Sophysa. So I will just introduce. I am the Clinical Affairs Manager for the Sophysa company. Our objective is to present you our perspective on CSF hydrodynamics and why we think it's important to take this standpoint as a shunt manufacturer. And so we had the chance to gather different specialties to tackle this issue. A neurosurgeon, a geriatrician, and a scientist on data analysis. So just as a brief introduction and a very simplified introduction, we will start with a brief movie explaining why we think it's important to take this standpoint. And after that, I will present the different speakers for today's seminar.
She's losing her autonomy because of walking difficulties with cognitive decline and falls. Her doctor thinks Mary is developing Alzheimer, Parkinson, cerebrovascular disease, or hydrocephalus. Her brain scan shows increased fluid volume with dilated ventricles suggesting hydrocephalus and reduced brain volume suggesting brain atrophy. Alteration of cerebrospinal fluid circulation can be better diagnosed by additional tools such as a tap test or infusion tests to measure ICP. Cerebrospinal fluid is produced in the brain and is reabsorbed in the venous system mainly through tiny sponge-like granulations. If granulations are permeable, fluid outflows freely with low resistance. Schematically, permeable granulations can be illustrated like a porous dam that maintain intracranial pressure under control not to damage brain function. But if granulations are clogged, fluid outflow is altered due to increased resistance. Clogged granulations behave like a less permeable dam, intracranial pressure is not sufficiently dampened. That might damage brain function. Infusion tests show that Mary has altered cerebrospinal fluid circulation. Her doctor thinks a shunt insertion will normalize intracranial flow. The neurosurgeon selects an adjustable pressure valve in order to customize the improved dam to Mary's needs. Thanks to CSF shunting, Mary improved her gait and autonomy. Bring a hydrodynamical solution to CSF circulation alteration.
So this brief introduction was just to say that as shunt manufacturers, we try to tackle the problem of hydrocephalus. But as you perfectly know, hydrocephalus is a complex issue with probably an hydrodynamic component. And the only part that we can treat with a shunt is the hydrodynamic side of hydrocephalus, which is the reason why we think it's very important to focus on this part. So as you know, a shunt is a tube in which you will have a very low flow circulation of CSF, and the shunt is also driven by differential pressure. The mechanism inside the shunt is very sensitive, so it can react to long period changes of ICP, like the changes you have during the day, but also to very fast changes, like the one related to ICP pulsatility. So the reason why we organize this seminar is because hydrodynamic of shunts is very important, and the behavior of the shunt is driven by the hydrodynamics of CSF. So the speakers that will tackle this issue today with us are Dr. Mendes, a neurosurgeon in France. He will explain his daily use of CSF hydrodynamics tests, both for evaluation of patients, but also for shunt malfunction assessment. After, we will introduce Mrs. Kazimierska, who is working in a lab in Poland and a specialist in ICP signal analysis. And she will treat the way we use CSF dynamic tested to have assessment of the hydrodynamics, but also give us some clues about what we could look further. And then we will finish with Dr. Villard, a geriatrician in France. She is online today, but she will present you her work and her conclusions about clinical outcomes that can be reached with this state of mind of selecting patients with alteration of CSF hydrodynamics to put shunts in these patients. So I now give the mic to Dr. Mendes.
So aging is a real question for actuality and for the futures, because with the increase of life expectancy, there is also an increase of dependence, and dependence could attain 60% after at 85 years old. So there is a cost, a big cost, and maybe we can prevent this dependence with a cost, but less, estimated to 10 billion euro in Europe for the futures. And iNPH, normal pressure hydrocephalus, is typically the pathology. For that, we can prevent dependency. The problems for chronic hydrocephalus, it's all other pathology. We don't respond with a shunt. Of course, everybody knows the Alzheimer's disease or frontotemporal dementia, depression, concerning the cognitive test. There is also prostatism or genital prolapsus. And for the walking, there is the arthrosis of the legs, arthrosis of the spine with myelopathy or neuropathies, and also all degenerations. And with all these pathologies, there is three things of Hakim triads, like Parkinson's or Lewy body dementia or iatrogeny. So in ANSI, we organize a specific and local pathway for patients. General practitioners at home could contact contact the hospital when it constates gait disturbance of cognitive impairment or urinary urgency. And we quickly organize an examination with a geriatrician. And just after this examination, if there is a more problem of walking, we reorient the diagnosis with spine MRI or X-rays for the orthopedist. And if it's a real cognitive impairment, we do encephalic MRI and an examination with a neurologist who organize a TAP test with work evaluation and cognitive evaluations. After, it's me to see the patient to organize and realize infusion test, new CSF depletions, and for an at-home evaluations. And with all this data, we decide with the family and the patient to go to the surgery or not. And just after the surgery, the patient go to rehabilitation before to go at home. Of course, after there is a follow-up, and the follow-up is typically 1 month after surgery, and after every year, all over the life. So we saw this morning that the role of the imaging, of course, with the dilatation of ventricles, evaluated by the events index, but also the acute causal angle, evaluated in the perpendicular to the ACPC line, not another plane. We don't really speak about the thing of the cingulate sulcus. It's difficult to apprehend. It's the posterior part narrows than the anterior part of the cingulate sulcus. But we speak about DASH with real importance in the diagnostic of chronic hydrocephalus, particularly at the beginning of the pathology. So the second step is the cognitive test and the neuropsychological examinations. In ANSI, we always realize race figures, a truth test, and a Montreal cognitive assessment, and the groove pegboard test. If the patient are okay, we try to do part or many parts of the waveforms. It's important to distinguish the dementia to the chronic hydrocephalus. Why? Because in chronic hydrocephalus, the more Impairment of cognitive state is the motor speech dysfunctions, attentions, maybe executive function, contrary to Alzheimer's disease or dementia, more severe attempt of orientations or memory. The TAP step is an important step for the diagnosis. So with the timer, we measure the time to realize 10 meters in stretch and the number of steps and the quality of the light. The quality of the work is really important to eliminate Parkinsonism with rigidity or asymmetry of the working. If there is a lacuna of the MRI, and we know that shunt is not have a good behavior, or the freezing for the work. At the end, we analyze the turning and the number of steps for turning. So we do this test just before lumbar punctures, of course. We make the lumbar punctures with the elimination of 60 or more milliliters of CSF. We stay a little 1 or 2 hours for rest, and after a new test to compare the before and after. The cognitive test is the same. We try to realize this test before and after. So with all these tests, we decide or not to realize an infusion test. In Annecy Hospital, we do the infusion test in the operating room for the quiet conditions. In neuroheptanalgesia with propofol and local anesthesia and with lidocaine. It's important to have no stress for the patients. So we install in a lateral decubitus, and we put 11 gauge needles on the L4, L5 the lumbar space without flush or elimination of liquid before, and immediately put the captor of pressure to measure the basal pressures. So we measure this basal pressure for 10 minutes or more to obtain a real good waves and good curves. And after we make the measure or the extrapolation of pressure index, pressure volume index, we inject a bolus of 2 or 3 and 4 milliliters. We purge the line to return to the basal pressure, and finally we do the real infusion test with electric syringe with a speed of 80 milliliters per hour on the way to obtain a plate of pressures. So we obtain this type of curves with at the beginning the setting, of course. We obtain the 0, up, we branch, we connect the captors, and wait in the yellow line, we recording the basal pressure. You can see on the arrow the bolus of 2, 3, or 4 milliliters. You can see the 0 for the purge of liquid and to return to the basal pressure. It's the same as the bolus for 4 milliliters. We purge, we recording a new basal pressures to do the ratio for evaluate the basal pressures. Extrapolation of PVI is the ratio between the delta of volume and the logarithm of the right pressures. And you know that air out is the delta of pressure, the ratio of delta of pressure with the speed of injections. For the limit of infusion test or not, so the basal pressure is of course 20 centimeters of water, PVI is inferior to 20 to NC, and resistance is superior or not to 12. So we consider a pathological test if there is 2 of the 3 value pathologic. The decision tree with all these exams, it's a real combination with the clinical parameters, imaging test, cognitive test, walking test, of course, and infusion test. So we correlate all this data and discuss with the patient and his family caregiver for the benefits to risk to a shunt. It's always a compromise. So we put, after everything is okay, an adjustable patient chart and continue to evaluate the patient. So just focus for the pathology, the physiopathology, how we have a CT scan like that at 20 years old and at 75 years old like Mary, so much CSF inside and around the brain. Of course, it's because of rigidity, but it's not the simple mechanisms. We know that in the vessel there is the rigidity with atheromatosis and atheromatic plates. This modifies the pulse of waves. And it's the same for the brain, who progressively with aging is more rigid. So arachnoid is thickening with aging and diminishes the flow of CSF, I think. It's typically for the DASH, it's trapping of CSF. And of course, there is a decrease of passive resorption of CSF. And progressively, by the equilibrium of pressures, microperfusion of brain decrease and metabolism decrease yet. Particularly in basal ganglia and the deep brain, and with the consequence we know. So now we put a shunt to Mary. She's called water the flowers. But there is a behavior change with the alteration and cognition and recurrence gait disturbance. She returned to the neurosurgeons and neurologists. And unfortunately, CT scan is comparative to the before shunt or just after the shunt is the same. There is no progressive augmentations of volume of CSF. There is no complications. There is no lacuna, no hematoma, nothing. We make some X-rays for evaluate the connection of the shunts. It's okay. We made find this. It's normal. So how to understand the problem? Infusion test can some arguments for the dysfunctions. And in ANSI, we try to understand this problem, and we retrospectively analyze 12, only 12, but 12 infusion tests realized with a shunt in place and with a suspicion of dysfunction of the shunt. So you can see the summer of the population with a median age of 56 years old, yes. Because it's not a homogeneous population, it's a population with chronic hydrocephalus for 4 patients and the other hydrocephalus for 8. And the shunt is not typically pressure adjustable valve, but there is a 4 flow regulated valve in these populations. The clinical symptom is principally headache, and just after the symptoms of chronic hydrocephalus, gait disturbance, and cognitions. So we do an infusion test for these patients in the same condition we explained before, in the operating room, neuroleptic analgesia, comfortably installed, half light, quiet at the evening, and practice at the evening of the journey of the day. And we put in the lumbar needles and recording the data like that. We don't realize the PVI because it's uninterpretable. And we have 2 criteria for revisions. The basal pressure superior to the opening pressure of the shunt, theoretically, or superior to 20 centimeter water. the second criteria is a resistance superior to 12 millimeters mercury by milliliter minutes. So it's a repartition of the patients. All pathological tests have an increased resistance, and 4 patients have a low resistance on the low beta patients. So we do a shunt revision for the high resistance, and particularly for the 3 patients with high resistance and high basal pressure. The results are like that. There is 6 improvements after revisions, 2 with nothing, and for the patient without surgery, we have just a focus. 1 patient with psychiatric troubles, and is unfortunately death, probably to another cause of dementia. 1 patient have cognitive disorders and progressively impaired. 1 patient and 2 patients have headache. 1 patient have no headache because he is modifying his eating to eliminate gluten. I don't know what, but it's like that. And the 4 patients continue to have the same headache after without explanation, but medication. So for the 2 patients who have no improvement after the shunts, there is a patient with a typically chronic hydrocephalus, and when we return to the surgery, we constate there is a little piece of fat in the peritoneal catheter, so we have UP, but not after he continued to have a headache, and particularly with the problem of overdrainage now, and we try to modify the pressure of the valve, but without success. The second is a hydrocephalus of a child. At the beginning, he had a flow-regulated valve, and we changed in emergency for a pressure adjustable shunt. Headache, we think it's because of the modifications of the tip of valve, but when we return to the surgery, we put a flow-regulated valve, but without success. Concerning his headache. At the end, the 4 cases we had infusion test before for the diagnostic of chronic hydrocephalus, and a new test for the diagnostic of shunt dysfunctions. And we can constate that the resistance are less elevated after a shunt dysfunction compared to the primary infusion test. For the last patients, there is a long time between the 2 infusion tests, 8 years, and I think it's progressively elevated resistance because of the aggravation of chronic hydrocephalus. So, of course, it's a small population. It's just for 10 years to have real tools to realize this infusion test. But we have 6 improvements for 8 patients. It's important because we avoid new surgery for 30 patients, for 4 30 patients. And we can, with the agreement of pressure, we can motivate the family and the patient to put a new shunt with successful, and to take the risk of a new surgery. So to take home message, the chronic hydrocephalus in adult is diagnosed with a combination of all arguments: clinic, with cognitive, walking, imaging, the depression of CSF, and the dynamic assessment of CSF. And then finally, infusion test is a tool to diagnose the hydrocephalus, chronic hydrocephalus, but also to diagnostic or to help to understand the problem where the patient have a new symptom with a shunt in place. Thank you. And now I give the micro to Agnieszka Kazimierska from Poland to speak about the reality of microwave and waves during the recording of CSF pressures. Thank you.
Good afternoon. Sorry. Good afternoon, everyone. So I will add a bit of a data analysis scientific perspective to the clinical perspective that was presented earlier, especially what and how we can learn from the Infusion study. So the model I will discuss has been around since the 1970s, is relatively well known, and it was introduced in the works of Professor Marmaru that we are all familiar with. And it's based on the idea that we can analyze cerebrospinal dynamics through a set of analogies between the hydrodynamical parameters, so the flow, the pressure, the resistance, and the electrical parameters that we can describe quantitatively. And it is generally a tool to assess CSF dynamics in a quantitative, repetitive way, which may give us additional information. And the electrical circuit representation of the model you can see on the right-hand side contains, in the usual presentation, 3 branches. We have the CSF production with the current source. We have the CSF absorption branch with the parameter that is most important to us, which is the resistance. But we also have the CSF storage branch with the cerebrospinal compliance. And if we present the model under normal conditions, so without long-term changes in blood volume, we can balance the CSF production and CSF storage and reabsorption, such as in this equation. And for the purposes of the model, we assume that the CSF production is constant, which of course may not be always the case. But we describe the CSF storage and CSF reabsorption with the following mathematical terms. So the rate of CSF storage is here dependent on the rate of changes in CSF pressure, which is the P in this equation, over time, and it's dependent on cerebrospinal compliance, so cerebrospinal compensatory parameters. But the CSF reabsorption depends on the gradient between the CSF pressure, P, and the sagittal sinus pressure, and it also depends on the resistance to CSF outflow. And this model allows us to mathematically assess what is the ICP response, or what we can derive from the ICP response we see, for example, if we manipulate the volume through bolus injection or through the infusion test. And if we consider the infusion test, we can rewrite the equation from the previous slide. So we have the term that is associated with CSF storage. We have the term that's associated with CSF reabsorption, but we also have the rate of external infusion, which in this case, for example, is constant for the constant rate infusion. And this representation is a tool to derive a set of parameters that describe CSF dynamics in a repetitive manner. So, for example, baseline ICP, but most importantly, RCSF. But it's also a method of fitting the analytical solution to the recording. You can see an actual recording of the infusion test in an iNPH patient on the left-hand side, and the fitted solution, the red curve, on the right-hand side. So the parameters allow us to describe the CSF dynamics in such a way that is clinically useful, as was shown in the previous presentation. But as mentioned, the most important parameter, and we are probably all familiar with it, is the resistance to CSF outflow, which in the model it quantitatively describes CSF drainage. And if the resistance is increased, we consider that there may be some disturbance in CSF outflow. And how it is calculated from the infusion test, it was hinted at in the previous presentation as well. So if we consider the 2 steady states from the infusion, if we consider the ICP at baseline and the ICP at the plateau phase and divided by the rate of infusion, then we get the RCSF values in millimeters mercury per per millimeters per minute. And the reason why this is the probably most important parameter of the model is associated with the fact that the shunts that we use are a method of influencing the outflow pathway of the system. So it has been studied quite extensively that increased RCSF may be a predictor of shunting in iNPH. And it's most studies actually show, and we have seen this in one of the presentations yesterday as well, that there is a long list of studies that deal with this aspect of CSF dynamics. And they all showed that there is value in this method of analysis, but the threshold is still a matter of some debate. Mostly, as we heard earlier, it's about 13 millimeters mercury per millimeter per minute, but some studies also suggested that maybe the value of 18 is more applicable here. And the consensus is usually that it's not a 100% yes or no indicator to the question whether a patient will improve after shunting, but it is an indicator whether this is a good avenue to pursue in this patient. And another aspect of this is that RCSF is also known to be age-dependent, so some studies suggest that perhaps we should use a different approach than the one-size-fits-all threshold. And it also may be influenced by the vascular factors. And here the CSF dynamics model will not help us, as the Marmoro model only models the CSF compartments. It does not take into account the vascular factors. This has to be assessed in different ways. But the different way that the model helps us to understand what is happening in the patients is the fact that if we consider the shunt a mechanical solution to the outflow problem, what it does from the modeling perspective, it introduces a separate pathway to CSF drainage, additional to the one that we have in the physiological conditions. So if we know what are the properties of the shunt, in this case the resistance of the shunt system, which may be variable, and the opening pressure, we can also analyze the model in the context of the shunt function. And this is a way of assessing the shunt function in vivo if we suspect that the shunt may not be working properly, as, for example, mentioned in the previous presentation, there's no improvement after shunting. Then we can assess what is happening with the shunt in place. So with the assessment of shunt function in vivo, usually through the shunt antechamber, we can identify various issues with the shunt in place. So, but this requires us to know two things beforehand. We have to know what the patient's CSF dynamics were before, because the shunt modifies what is already happening there. And we should know what is the expected operation of the shunt, and there's been a lot of work done on this front. And if we assess the CSF dynamics of a shunted patient, this can help us to decide if a revision is in fact required, or if we should actually pursue some other method of diagnosis. And that's why resistance to CSF outflow has such an importance for general assessment of CSF dynamics. But this is what we know now and what we use now mostly. But there are actually other avenues that couldn't possibly be explored from a data analysis perspective, from an ICP analysis perspective. If we move beyond the RCSF. So in the Infusion study, if we monitor ICP, we monitor also the pulse pressure. And another avenue that can be explored is actually what we know about the cerebrospinal compensatory reserve. So not just the outflow arm of the model, but also the pressure volume compensation. And one of the parameters that is used to describe it from the model analysis is elasticity, or elastance index, which theoretically, and that's why the quote is the stiffness of the system, or is the inverse of the compliance of the system. And in this case, it's calculated there in various ways depending on the method used, but it's usually dependent relationship, the calculation method is dependent on the relationship between mean ICP and the pulse amplitude of ICP, and an estimation of the effective increase in CSF volume either through modeling tools or through MRI measurements. And given that it's based on the relationship between mean ICP and ICP amplitude from the infusion test, this is usually assessed in the increase phase rather than the steady state that we analyze to derive a route. And the exact significance of that still actually remains unclear. There are some usually single-center studies that suggest that increased value of E, which means the reduced compliance, may be predictive of outcome after shunting, but those are not definitive. But it does help us assess the pressure volume compensation in a different way than the compliance curve, because what you see on the left-hand side is the compliance curve from the model. And you can see here that while compliance is dependent on the ICP level that we measure, the stance elasticity is the coefficient that we can use here. And a different method, but this is very much a work in progress to assess the pressure volume compensation. Yes, and I'm sorry, just one more comment on that, that the significance of elasticity may actually be important for the fact. Something that we observe is that some of the patients present something that's called the hysteresis of the pressure volume curve, where the pressure volume curves, you can see them on the right-hand side, are actually different if we assess them from the increased phase of the infusion test or the decrease, and the difference in ICP may be the result of changes in elasticity. But now to the different methods. So the ICP pulse waveform, which is often recorded but not very well explored in hydrocephalus. Generally, we consider the ICP pulse waveform the short-term oscillations that are synchronized with heart rate, and they are induced by changes in cerebral blood volume. And we are interested in them because there is a good reason to believe at this point that they contain information on cerebrospinal compensatory reserve that may provide additional information to what we already measure. And the most widely used method of assessment is the pulse amplitude based on the pressure volume curve that shows us that the further we move on the curve, the higher the amplitude, because of the increased pressure response to a given volume increment. And this was the basis of a parameter called the RAP index. That is the moving correlation coefficient between mean ICP and the amplitude. So the further we move on the curve, the more correlated, the more strongly correlated the two parameters are, the mean ICP and the amplitude. So we can observe that in patients with RAP moving towards 1, we can say that the compensatory reserve is significantly reduced. You can see that in the infusion test recording example on the left-hand side. And the importance of assessment of the compensatory reserve was shown in a study that suggested that not only we see changes in RAP before and during infusion, which we expect based on the fact that by adding volume we increase the mean ICP and thus change the compliance, but also we saw changes we can see changes in RAP before and after shunting. We can see that the compensatory reserve is actually improved after shunting, but it's also significantly worse in patients with a blocked shunt. So it can be used as a method of additional method of deriving information from what we see in patients before and after shunting, and after the shunt is already in place. And the different, slightly newer method, although it has been suggested a long time ago, method of analysis is based on the pulse waveform shape. And this is a relatively novel concept. So from what we know about the ICP pulse waveform in normal circumstances, we see that if we measure, in this case, ICP intracranially rather than through the lumbar puncture, we can see that in normal compliance conditions, the first peak of the waveform dominates, but as we move towards reductions in compliance, then the second peak starts to dominate, eventually the waveform is rounded. And there is a study that we did to see whether this is actually an appropriate measure of compliance. And we saw that the changes in the P1, P2 ratio are actually strongly correlated with what we see during the infusion test in compliance analyzed using the Marlborough model, and with the coefficient of almost 0.8. We also saw that if we consider the baseline prior to the infusion test, the decreased baseline P1, P2 ratio, so the increase in the second peak, is actually associated with increased elasticity, so worse compensatory parameters. But because the assessment of the peak ratio is relatively difficult from a technical standpoint, there was a different method suggested that is based on classification of characteristic shapes of the waveform. And there is a study that suggested that we can find 4 characteristic classes there. And if we analyze again the pulse shape at baseline, then we can see that the more pathological the class, the more pathologically altered the waveform, the higher the elasticity that is estimated based on the entire infusion test, but here we're looking at the baseline only. And if we divide the patients into those with normal elasticity versus those with increased elasticity, then we can see that the pathological waveforms mostly occur in those with worse compensation. And this led us to a question that I don't have the answer to yet, because it's what we're trying to answer now, is can we add additional information on the cerebrospinal pressure volume compensation based on the baseline recordings? So can we not use volumetric manipulation to actually derive that information, so without bolus injection in some patients, to limit what we have to do there? So to sum up, the mathematical model that I discussed, that has been around since the 1970s, is a useful tool to quantitatively assess CSF dynamics, and it allows us to compare what we observe in the patients before, after shunting, and when a shunt is not functioning properly, or we suspect that it's not functioning properly. And the most important factor that we consider here is the resistance to CSF outflow, which has been shown a good predictor of outcome after shunting. And the ICP pulse waveform analysis, on the other hand, may help us assess the cerebrospinal pressure volume compensation, but there are further studies required to actually confirm that this is useful in the clinical setting. And now allow me to give the floor to Dr. Villar, who will present a different perspective. We had the neurosurgeon's perspective before, and now we will be moving on to a geriatrician perspective on the usefulness of infusion studies and CSF dynamics assessment. Thank you.
Thank you very much. Can you see my screen? Thank you very much for giving me the opportunity to share with you today. Sorry not to be there. I'm a geriatrician at the Toulouse University Hospital. And can you see my screen? Just tell me if it's okay. Yes. Okay. So I would like to talk about hydrocephalus in older adults, considered as a reversible or potentially reversible loss of autonomy. I would like to start with this slide illustrating the fact that geriatric neurosurgery is a new field of research. In the past 5 recent years, occurred works on geriatric population. Older adults are enrolled in studies, but not often benefiting from any geriatric care or geriatric approach. Indeed, geriatric is a proper discipline, a field of medicine of 50 years of age, and is now evolving and moving towards a more preventive approach to maintain healthy aging and to promote healthy aging. Our goal is to maintain intrinsic capacity of the subject, of the older adult, and his functional autonomy in daily living. Avoiding dependency is a major goal of care for us, and pursuing the choice of aging in place for the majority of persons. Indeed, we are all growing old. Many of us have the chance to grow old. And you see on your right, 50% of subjects of over 65 years old are in a trajectory of normal aging, which is a trajectory with minor diseases, with independence, with living at home with relatives and caregivers. On the contrary, on your left, you can see that 5% of persons over 65 years old are suffering from a pathological aging with severe diseases, neurodegenerative diseases such as Alzheimer's, of course, dependency, living in nursing home or residential facilities. And in geriatrics, 20 years ago, a new concept of research and now implemented in clinical practice emerged, which is called the frailty syndrome, which is a reversible state on which intervention can be done to reverse and to put the people in a more normal trajectory of aging. Frailty has been defined by a researcher called Fried 20 years ago, and it is defined by 3 of the following criteria: an unintentional weight loss, a self-reported exhaustion, a muscle weakness, a walking speed in the lowest 20%, and a low level of activity. And for me, as a geriatrician focusing on autonomy, I have been progressively interested in normal pressure hydrocephalus, and I discovered in the literature and in my patient that it is widely underdiagnosed among older adults. Normal pressure hydrocephalus is a relatively rare cause of 3 very common symptoms for us, which are gait disturbance and falls, cognitive dysfunction, and urinary incontinence. Those 3 symptoms are very, very common for us. It's a well-known geriatric condition, but normal pressure hydrocephalus is not always envisaged by geriatrician. And those 3 symptoms impact the old person functional autonomy and increase the risk of falls, which is a sentinel event, a red flag for us, because life expectancy is impacted by falls, emergency department admission, but also the aging in place choice and inappropriate healthcare system utilization. So falls is something we are fighting against in geriatrics. And amongst subjects who falls, there is a minor percentage of people suffering from NPH, but we have to improve our diagnosis process now. Because the reality we are facing is complex with differential diagnoses, vascular dementia, Alzheimer's, of course, hydrocephalus, and Parkinson's disease. And moreover, there is a lot of interplay between those nosography. And it's much more complex. This is supported by evidence, protein abnormality, neuron loss. We are discovering now that the subject has often many causes of his neurodegenerative symptoms, cognitive dysfunction, gait disturbance. So the partnership between neurosurgeons, as previously said by my colleagues, of course, and geriatricians is essential to improve the diagnosis. For example, in our ambulatory unit in Toulouse, in which 1,000 persons are admitted per year with a mean age of 85 years old, very old person. The diagnosis process is made by ventriculomegaly on brain imaging, of course, neurological examination, because it's often neurologists that address older patients to our unit, and a true comprehensive geriatric assessment. Comprehensive geriatric assessment is a set of tools used by geriatricians to assess the status of the person. So nutritional status, cognitive status, vision and hearing impairment, risk of falls, polypharmacy, comorbidity. It's a real screen of the older adult that allows us to improve the diagnosis, but also to manage the follow-up and to stratify, to make a risk stratification for every treatment, surgery, neurosurgery, of course, but also cardiology and also chemotherapy, for example, in oncology. It's a real tool to make a risk stratification for people. So when the CSF dynamic parameters is added, the number of diagnoses is increased in our unit. Initially, we performed the TAP test, but now we are making the infusion test since 7 years, because the effect of the TAP test is not easy to assess for an old person who is suffering from memory loss. It's not easy to compare the previous state to the state. And with a lot of comorbidities, people have other reasons to be impaired in their gait, in their walking function. So the infusion test performed by my colleague, neurosurgeon Dr. Schmidt, improved the diagnosis in our unit. And it is important for us because the literature shows that among symptoms of normal pressure hydrocephalus, reversible after shunting, it is gait disturbance and falls that are the most improved, because the voluntary postural control is improved and reduce this risk of falls. And as previously stated, it's important for us to reduce this risk of fall, to maintain autonomy and aging in place for the people. So this multidisciplinary expertise is required at the time of the diagnosis, but also to minimize unsuccessful surgical treatment and to lessen adverse effects. Indeed, among older adults in our population, the risk of neurosurgery is increased, and expected risk of neurosurgery among older people are, for example, been studied by this study published in the JAMA recently. It's a retrospective cohort that shows that 20% of people after a neurosurgery procedure experimented functional decline. And the author have identified risk factors of this functional decline. Among those risk factors, there is non-geriatric risk factors, for example, an emergency surgical procedure, operative sepsis, but also cancer and postoperative complication. But there is also truly geriatric specific risk factors that can be assessed by our comprehensive geriatric assessment. And this is an history of fall, a preoperative mobility aid use, preoperative malnutrition, postoperative delirium, of course, postoperative pressure ulcer, and mobility aid at discharge. So it's important for neurosurgery to be aware, neurosurgeon, to be aware of the importance of geriatric risk factors of functional decline among older adults. And to illustrate the impact of shunting in our population, I would like to present the results of the Sophysa study, which is a monocentric clinical study on normal pressure hydrocephalus shunt outcome. We have retrospectively analyzes data on shunted patients with CSF dynamic tests. The iNPH was suspected after clinical examination and brain imaging. The infusion test was performed with 4 categories of profile, normal or subnormal profile, and pathological or strictly pathological profile. Then the shunt was performed and the follow-up organized yearly with 4 categories of assessment, -1 hydrocephalus worsened, 0 no change, +1 improved, +2 greatly improved. Of course, it's subjective, but it was important to assess the impact. 325 patients were screened, but only 202 reselected in statistical analysis because 5 of them suffered from serious adverse events, 29 were lost in the follow-up, and 89 has no shunt performed. It was a very masculine population and a mean age of 70 years old, which is relatively young for us in geriatrics. So operative complications occur in 5% of people, and the complications were neurological, digestive, headache, infection, for example, which are known. Let's see the results. You can see on the gait function on your left that 35% of people recovered a normal gait function, which is very rare and very impressive for a result in the field of geriatrics, because the majority of neurodegenerative diseases are not reversible. Our aim is to maintain intrinsic capacity, to avoid the loss of autonomy, but it's very rare to reverse any process. And in this study, we have shown that many of them have been recovering normal functioning. The same trend has been observed in urinary incontinence and also in cognition, with unfortunately some missing data. You can see on this slide that the majority of persons at the early follow-up experimented improvement or great improvement. At the immediate follow-up, there was a significant gait improvement, and it remained positive 6 years after the shunt. That is also very rare in geriatric to have such a long follow-up in patients. You can see the probability of observing any improvement in gait from baseline 2 years after shunting, which is very high in 91% of people, and then in decrease after 4 years. The same trend is also observed in urinary disorders, with a moderate improvement and a slight improvement in cognitive disorders. That is known in the literature. It is known that it's much more walking and gait disturbances that are improved by shunting, much more than cognitive dysfunction, executive dysfunction, or memory loss. Of course, there is limits in these studies. It's a monocentric study. It's a retrospective study, non-comparative with no control group. Indeed, it's difficult to make control group in randomized controlled trial, assessing the impact of any surgical technique. On an ethical point of view, it's difficult not to propose the surgery the person is in theory eligible for. And another limit is the loss of missing data in the follow-up. But we can emphasize that the improvement of walking disorders and gait is great and maintained 2 years after the shunt among older people. So I have tried to shorten a bit my presentation, but my take-home message would be there is a need to improve the diagnosis of normal pressure hydrocephalus among older adults suspected from it for 3 main reasons. First, the pathophysiology is much more complex than we think, and it's multi-component, and we have to manage this complexity. Then falls and consequently autonomy are expected to be improved by shunt in the literature. And adverse effects of neurosurgery could be avoided in people with normal cerebrospinal fluid circulation and or with a balanced risk-benefit negative. It is important to target the right patient, the patient who will benefit from the shunt and who will not have a high risk of adverse effect or high risk of loss of autonomy, of delirium. We have to try to find the person eligible in theory and who practically will benefit from it. This multidisciplinarity is needed around the geriatric patient, the neurological examination, of course, the CSF assessment, infusion test in our case, and this comprehensive geriatric assessment. Because reversibility of normal pressure hydrocephalus symptom is described in our population and expected in a very well target subpopulation of older adults. Thank you very much. I will stop the sharing. If you have any questions.
Thank you very much, Dr. Vela. So in order not to delay the meeting, maybe we have time for one question if you have. And if not, of course, all of the present speakers will be happy to answer after the meeting if you need. Thank you very much for your attention, and I wish you a pleasant end of meeting. Thanks.